Good morning. It's a great pleasure to join. I apologize. I had 1 extra hour of sleep because I mixed up time differences, but without any further ado, it's a great pleasure to introduce Benny Brenner from Israel. And Benny is going to share with us the state of art with cancer and thrombosis in 2020. Much has happened, so very interesting. Benny.
These are my disclosures. Now, when we know that cancer increases blood coagulation and thereby inferring thrombosis, of course, venous thromboembolism, which is the topic of this talk, but more recently, there is epidemiological data on association of arterial thrombosis with cancer, which is quite interesting and important. And also, we understand that clotting activation may affect cancer progression, but this is really not the topic of my talk today. So I will touch upon epidemiology, then go to risk assessment, and finally to management of cancer-associated thrombosis. So this is about 20 years from Denmark, showing that having cancer with venous thromboembolism is associated with reduced prognosis. And cancer-associated thrombosis can be lethal. With venous thromboembolism, actually pulmonary embolism mainly, is the second cause of death in cancer patients, and about 10% of patients associated with early mortality with patients who are receiving chemotherapy, and about 50-fold increase in the risk of mortality associated with venous thromboembolism. And from this Impact Healthcare Claims database by Gary Lehman, you see that actually in cancer patients who receive chemotherapy, venous thromboembolism continued to increase over 1 year. And this is for 5 types of cancer, for bladder, from about 10% at 1 year, and pancreas up to 21% of venous thromboembolism at 1 year. Now, of course, this brings us to risk assessment, because some cancers have high risk of thrombosis, while other cancer, like breast cancer and prostatic cancer, have relatively low risk of venous thromboembolism. Now, it's about 12 years now after Corona published his Corona risk assessment score for cancer patients receiving chemotherapy, and this has been actually suggested to be included in some guidelines, including the NCCN guidelines, because this is a simple score based on the site of primary cancer and the blood count and BMI. And then you get the low, intermediate, and high risk score, and you can see the risk of symptomatic VTE accordingly. However, this coronary score has some strengths. Its simplicity, high negative predictive value. It can be predictive of benefit from thromboprophylaxis as well as mortality, but it has some limitations, which is low positive predictive value. The majority of patients are classified as intermediate, and it's not consistently effective in single sites of cancer, especially lung cancer, as shown by several studies, including recent meta-analysis, which Harry was by Van Es, which Harry was part of. So there have been some other suggestions for risk assessment models. Several variations of the coronary score have been suggested. The Vienna group, the Vienna CAT score, the PROTECT, and the CONCO score. The OncoTEV score is based on Corona score of more than 2, then adds metastatic disease, previous VTE, and vascular or lymphatic compression. The COMPASS CAT risk assessment by Gregor Ziafas was developed to use only mostly breast cancer patients, the majority of patients in this score, then colorectal, lung, and ovarian cancer. The Trolley score by Antich for lymphoid malignancies, and Andres Munoz from Spain suggested a combination of genetic clinical factors in the TIC OncoScore, which performed better than a coronary score in identifying patients with cancer who are at risk for VTE. And this brings to these four parts of cancer-associated VT risk, because they are patient-related issues, as you can see, then the tumor-related, depending on the tumor itself, and treatment-related, whether the patient receive chemotherapy, anti-angiogenic agent, surgery, hormonal therapy. And then the biomarkers, you see the simple biomarkers with the Corona score, the blood count. Then there are more sophisticated ones like microvesicle TF or TF-TFPI ratio, Parnas procoagulant activity, planning, but all of these are actually more for research, but not for clinical use. And then comes the question what to do with the dimer, which usually is increased in patients with cancer, even without venous thromboembolism. And recently there was a suggestion by the Vienna group of checking the D-dimer as longitudinally, looking at dynamic assessment of the dimer. And actually what they have able to show in the group of patients from the Vienna CATS study, that the dimer increased before the onset of cancer-associated VTE, and the dimer remained constant over time in patients without venous thromboembolism. And this actually enabled highly personalized dynamic prediction of venous thromboembolism based on the dimer trajectories. Moving to the last part of my talk, management. Now, we know that prophylaxis with low molecular weight heparin in different clinical settings in cancer patients is very effective. It's effective in the post-operative scenario and for major abdominal surgery and pelvic surgery in cancer patients. You can see that it reduces significantly the risk when you extend treatment compared to conventional short treatment. And the number needed to treat is about 40 to 50. The same is true for hospitalized cancer patient. Again, nice reduction with a good, relatively good number needed to treat for a short period of time. The problem is the outpatient cancer patients, and this is a majority of the cancer patients, because then you have to really give the thromboprophylaxis for a long time, 3 months, 6 months, and this is quite problematic because the number needed to treat is, again, by previous studies, is 50 to 60, unless you go for a high Corona score, as mentioned here, and then it goes down, the number needed to treat to about 12 to 15. Now, 2 recent studies with DOACs showed relatively interesting studies. And this is the AVER trial by Mark Carrier, looking at apixaban therapy. And this resulted in significantly low rate of VT compared to placebo among intermediate to high risk ambulatory patients with cancer who were starting chemotherapy. However, there was a price to pay, which was a somewhat increase of major bleeding episode, 3.5% compared to 1.8% with placebo, and this was significant. Alucorana in the Cassini trial looked at a high-risk ambulatory patient with cancer, and during the intervention period, compared to placebo or rivaroxaban at a thermoprophylactic dose, led to lower incidence of VT without significant difference in major bleeding, but you see it's 2% versus 1%. And I think we should really look at that, comparing to low molecular weight heparin, the upper 2 lines. You see that, first of all, low molecular weight heparin thromboprophylaxis is efficacious in high-risk ambulatory cancer patients, especially in pancreatic cancer, but also in some lung cancer patients. And a recent meta-analysis showed that the price is about 2% risk of major bleeding with low molecular weight heparin, compared to 1.1% without thromboprophylaxis. So this leads to some guidelines. These are the recent ETAC guidelines, suggesting that primary prophylaxis with low molecular weight heparin, vitamin K antagonist, or DOACs in ambulatory cancer patients receiving systematic anti-cancer therapy is not recommended routinely. Regarding low molecular weight heparin, there are indicated in the specific case of locally advanced or metastatic pancreatic cancer treated with systemic anti-cancer therapy who have low risk of bleeding. And with the DOACs, according to the AVERT and Cassini, primary prophylaxis with DOACs is recommended in ambulatory patients, cancer patients who are receiving systemic anti-cancer therapy at intermediate to high risk, identified by either cancer type, for example, pancreatic, or a validated risk assessment model such as the Corona score, high Corona score, and not actively bleeding or not at high risk of bleeding. Now, for patients with myeloma who are treated with immunomodulatory drugs combined with steroids or other systemic therapy, primary pharmacological prophylaxis is recommended. This is a grade 1A recommendation. Now, over the past, coming to therapy of cancer-associated thrombosis, over the almost past 20 years, we have used low molecular weight heparin to treat cancer patients with established venous thromboembolism, and this is following the Agnes Lee trial, the clot trial, showing that dalteparin, the clot way, was significantly better than vitamin K antagonist. And you see the number needed to treat was 13, which is quite reasonable for injections, daily injections with low molecular weight heparin. And the price to pay in terms of the clot trial was actually not much, as there was no difference in bleeding. Now, recently, the DOACs were introduced, and the first large study with DOACs in patients with cancer-associated thrombosis was the Hokusai VTE cancer trial. And it looked actually at over 1,000 patients who received either edoxaban 60 milligram or dalteparin, the clot way. And as you can see here, looking at the efficacy and the safety, you see that while the efficacy was non-inferior to dalteparin, numerically lower, but statistically non-inferior. The safety, there was some increase in bleeding. And the same results were actually found with the much smaller study, the SELECT-D trial. You can see here that there was a good efficacy, but there was an increase in bleeding. And we have to remember that mortality in patients with VTE inactive cancer, and this is from the Riete, is first of all, patients who are on anticoagulants is due to fatal bleeding. And this is more than fatal recurrent PE and fatal arterial events.
Benny, we're going to have to run out of time. Benny, you're running out of time. You're going to have to end now. Sorry,
yeah,
Benny.
Okay, so sorry, I'm ending. I'm just showing the Caravaggio study results. And as you can see here from the Caravaggio.
We'll answer questions during the break. We'll take your questions during the break.
Okay, so as you can see from the Caravaggio study, we see that when apixaban was compared to dalteparin, apixaban was associated with, it was not inferior to dalteparin, where in terms of major bleeding, there was no difference between apixaban and dalteparin, being major bleeding in the GI or out of the GI tract. And this actually expand the proportion of patients with cancer-associated thrombosis who are eligible for treatment with the oral direct anticoagulants.
Thanks, Benny. We have to end.